All right. Thanks everyone for being here. Appreciate you having us. I'm Will Hartmann, not native, he, him pronouns. I'm up at the School of Interdisciplinary Arts and Sciences at UW. That's where I've been since 2016. Great home. And our thought was, so the talk's about, well, maybe do you want to say a brief introduction for keep going. So we're talking about centering community and strengths-based research. And my first steps down the road in this direction was around centering community. I was really fortunate to have a research mentor in my doctoral program, which was a clinical psych program at the University of Michigan. It was a community engaged researcher, did different forms of community engagement. And so year one of grad school, I was able to kind of slide in under his wing into a community collaboration. It was really rewarding and kind of a formative moment for my graduate studies experience. And the idea, I should have said, is to give a little bit of background context to how we came, to doing what we're doing. So the year before I showed up at Michigan, there had been a health needs assessment. This was an urban American Indian community in a large Midwestern city. And there was overwhelming interest among community members in accessing traditional healing services in their local IHS clinic, IHS funded clinic. And so the administrators of the health organization were really interested in unpacking what that meant, what that could look like. There are lots of questions around, so for those who aren't familiar with urban Native communities in the US in particular, many have multi-tribal membership. Many were populated through a good part in these federal relocation programs, which is one of many assimilation efforts by the federal government that encouraged Native people, incentivized and pressured Native people to move off reservations into large urban centers across the US as this part of this hope or federal intent to assimilate Native people into an idea of melting pot society. And so membership was multi-tribal. Traditional healing raises questions around whose traditions get represented, how. There's also the relocation element. So lots of community members, we got to think about which traditional healing practices travel well, which ones make sense in a clinic setting or a health organization setting. So there's all kinds of questions that the health administration, of health organizations administrators had. And so focus groups were conducted with community members. I got to analyze transcripts from those. I did a fairly descriptive analysis of like what traditional healing community members had in mind when they said there was this overwhelming interest in accessing those services, what could it look like, and also what were some of the likely tensions that the health organization and larger community that use that organization might run into if those services were incorporated. And I got to not just publish that research, but also present it to health organization administrators, staff, and a traditional teachers council that was influential over how services got organized and how community was thought about there. And it was really well received. It was really exciting. It was kind of a formative moment because I got this real palpable sense that research is useful or can be useful. When communities and community partners kind of define some clear need, and research skills can be really used to meet that need. And that was something that a number of my classmates at the time, or cohort mates who were doing more basic research, struggled to get a sense of how research could be useful and for particular people in particular moments. And so that was pretty formative. I was really jazzed about like not just the past and perception, but also this idea that research could be useful, and I had some skills that might be appreciated and put to use. I then went back to classwork. I went back to clinical training, so clinical psych program, teaching assistantships. And I pretty quickly in the first year and a half got a sense that there was a pretty wide gulf or divide between how human health and hardship and distress and healing were thought about and talked about in my program in the Native community context. And I started to think about this in terms of discourse. So there are frameworks for thinking and talking about interpreting human suffering and hardship and distress that I was getting socialized into through clinical psychology as a profession. And there were ways the Native communities talked about this, and they were quite different. There wasn't a lot of bridging between the two. So I became really interested in how to think about those bridges and where they were and what was going on, where Native communities and mental health professionals were using similar conceptual frameworks, similar terminology to talk about what's going on in Native communities. That led me to develop an interview project on historical trauma as one of those bridges where Native communities and mental health researchers were using the same language to talk about distress and healing in Native communities. So I went to a Great Plains reservation where I knew some folks and spent some time, spent a summer getting a sense of how different community constituencies talked about history and how it matters for life today, including hardship in life today, and also historical trauma. So not just historical trauma, but I wanted to get a sense of comparatively, you just think about history and its relevance today. versus think about it in terms of historical trauma, what understandings came to the fore. Two big takeaways that I took away from that project. One was a real sensitivity and concern around misrepresentation. So I get a sense that, so for example, I interviewed health and human service providers and traditional healers, and actually all but 1 out of 2 dozen or so were familiar with this historical trauma term and used it comfortably. But only 3 out of 2 dozen or so used it in the way that you would read about it in the mental health literature. So as background context, historical trauma was this novel combination of 2 pre-existing ideas, historical oppression and psychological injury, based on traumatic trauma concepts related to PTSD, but expanded to better encompass the kinds of violence and the experiences that Native folks have and struggle with in some Native communities. And put those together in a concept that's supposed to better capture those experiences in Native communities and inform interventions that are more relevant to life experiences. But that psychological trauma, that psychological injury or wounding, hardly came up at all. Only 3 mentioned it out of, say, 22 or 24 interviewees that I talked to. And all 3 that mentioned it also talked about historical oppression as like a social analysis, like a phenomenon that is political, economic, and social and structural in those ways without any psychological wounding. And one thing that really stuck with me is that all 3 who talked about psychological wounding and historical oppression, to switch between those ways of thinking and talking, had to invoke the perspective of a third party. So like such different ways of thinking and talking that to go from talking about like a social analysis of historically rooted in ongoing oppression and how it's created hardship and challenges in life for life today, to psychological wounding. Interviewees, health and human service providers had to say something like, I heard someone else on the radio say, or what about this lyric that I heard from a Native musician who sung a song about this thing? So there's really different ways of thinking and being and understanding, interpreting the role of history in shaping life today. So much so that there was no smooth kind of multi-layered, multi-level kind of transition between thinking across levels of analysis. There's a really different ways of thinking and interpreting life experiences. So I became concerned that there's this real possibility to misunderstand and misrepresent what Native people wanted to say when it came to health and history and healing today. And the second thing was about power. Just the power of, the second takeaway for me was about power of knowledge production as researchers, that there's a real sense of narrative control over who Native people are and what health concerns there might be and what to do about those concerns. So I took those 2 sensitivities and lessons away as I went back to campus. This is now year 3, where I've got lots more control over the kinds of coursework that I take and things like that. I took medical anthropology and sociology classes to get a better sense of how to attend to local experiences and kind of prioritize their privilege, what people are saying in their own frameworks, in their own language, as opposed to translating them to mental health concepts. I did a settler colonialism reading group with the Department of American Culture at University of Michigan. That was really formative. It was around Audra Simpson's Theorizing Native Studies edited book, I want to say 2014 or something like that, that came out. So that was really formative to be around folks who are thinking about settler colonialism, just to advance the ways that I could think and talk about structural violence and challenges that have, as they play out in Native communities. And the third was the field of community psychology. So I got interested and professionally involved in this field called community psychology. It's a lot like social medicine, for those of you in medicine and public health, but very much thinking about power and context and social justice as a value, recognizing that research is an intervention and that it's always going to shape the world around us. And so you should think about that and be transparent about the values motivating the research. That professional group and that professional community really helped me to think and gave me this visual metaphor of what I would talk about as like top-down versus bottom-up approaches to research. So top-down being the one I was concerned about, that starts with what are the existing mental health theories and concepts and practices and even like terminology, and how do those help me make sense of what's going on in a particular setting? And the bottom up being, let's listen very carefully and closely to what people are saying in the language and in the settings and contexts that are familiar about what's going on, what their concerns are, what their desires are related to health, and then extrapolate, build up, and see how that connects to what researchers think they know, and see what connections and differences there are. So I developed a real sense of that framework of being concerned about and interested in bottom-up research as a way to respond to the sensitivity around misrepresentation and power and things like that. So some experience in community engaged research. I don't know if it's quite centered at that point, but I was interested in communities defining an issue or an interest or a problem and setting the terms of how to go about addressing it. I was interested in community partnerships and relationships. And so those are things I had experience in. And the strengths-based stuff wasn't until I got to Bothell or to UW more broadly. 2016, I started here, and I'll say that during my early career phase, there are three main influences. The first was Gerald Misner, an Anishinaabe literary theorist who coined the term survivance, which I think of as like a mischievous combination of survival, resistance, endurance, persistence, a lot of kind of words that refuses to settle into any one thing. And that's why I think of it as like creative and mischievous, because it kind of refuses to be defined in a way that you could ever count on for a long time. I got to work with some colleagues here in American Indian Studies, both at Seattle campus and at Tacoma. So Danica Starue-Miller in Tacoma, and Chad Allen, and Dia Million here at the Seattle campus, and a group of Lakota artists that I had gotten to know. We did this public scholarship project on creative community practices and survivance. So that was really cool to be able to sit down with people super brilliant and a group of artists that really pushed me to think not just about health and healing, and say like traditional healing, which was more in my wheelhouse of thinking about healing as a health practice, to think more broadly about community wellness practices that might be less recognizable within, say, like a clinical training framework of healing problems that exist, and thinking more about health promotion and community collective wellness and a broader array that include art, but also include storytelling and other kinds of things that bring community together and mobilize or organize around some shared vision of a better future. So that was really important. Eve Tuck's desire-centered versus damage-centered, some of her writings about those things. So that's an important distinction that made a lot of intuitive sense to me, but it made it also clear that I had been really concerned about concerns and had lots of concerns. I was interested in power in the abstract, but didn't really hadn't spent and invested the time to get a sense of like what desires look like and how to, who to get to know, to get a sense of what those community desires might be, and really like lean in to what, starting with desires around what hopes and desires for the future of health and wellness, how that might lead to a different set of research activities. And the last one would be American Indian Studies colleagues here at UW. So especially before I had two toddlers and before the pandemic, there was lots more social engagement and kind of writing groups and things like that. So I got to listen and read how some of those amazing scholars who work in the Native communities thought about their work and just have different models for what scholarship could look like. There's one weird moment that, one moment that stuck out to me. I'm sure this individual didn't think it would stick out, but they were giving me feedback on a manuscript. This is Josh Reed, a Snohomish historian here at UW, and he used the word particularistic as he was, giving me feedback on the methods section of a paper, and that really just stuck with me as like I needed something to push back against the pool in health sciences and medical sciences, to push back against the draw of generality and generalizations and decontextualized knowledge that pursues this kind of universal human subject and processes and pathology, and think not which has its own power, but think about like the power of particular stories with particular actors and particular places that really can inspire and anchor something in a specific people and a specific cause, as really important that I hadn't thought a lot about. So that was another kind of door opening to really lean in, that both maybe shifted some of my community engaged work into kind of community centered work, to think about who are the actual specific people and resources and activities there that I could be informed by and help amplify or help kind of buttress. And then also help me think about a lot of these strengths, how I might organize inquiry and research activities around strengths that, till I met Dr. Rachel Wilbur, I didn't get a chance to kind of put into practice. So I had lots of interest in strengths-based work. I think I was thinking very community kind of centered in those ways. And that's where I was when we connected. Share a little bit of how you got to where we are today.
Yeah. So we were both told to kind of think about our stories and how we got here, and I think really illustratively of how different our paths were. Our stories are very different, and the way we thought about this was very different. So I'm going to go off on a bit of a tangent. So my name is Rachel Wilbur. I'm a research assistant professor at Washington State University. I'm also Native, and the way that we are taught to introduce ourselves is to say who we are and where we're from. So I'm descendant Talawa and Chetco through my mother. My homelands are in Northern California and Southern Oregon. It's now Northern California and Southern Oregon. My great grandmothers are Tomawapa Suni and Masumja. And my other grandmothers are Clara and Margaret and Rose. My grandfather is Victor and my mother is Shannon, so it's kind of my lineage. I come from the Van Pelt and the Lopez lines of Taloa. So those are two of our big families. And my relatives are on the Taloa Dini Reservation, the Big Lagoon Reservation, and up at the Confederated Tribes of Siletz. So that's kind of where I come from. Lived in our tribal territories until I was 5 and then moved up to the Seattle area. And was raised largely outside of my community, although I did go home. My grandfather raised me in the summers, so I got to spend summers back home. Went to the University of Washington, thought that I was going to be a doctor. I think that's not an uncommon place that people go. I didn't really have a lot of experience with higher education. Most people in my family didn't go. And so I was kind of figuring things out as I went. Got through a couple years doing chemistry and calculus, and then decided it was not for me. I was more interested in understanding what made people sick and how they might be, how sickness might be prevented or how wellness might be achieved rather than like medicine per se. So I stumbled into medical anthropology, and I still really enjoyed that, but I still thought of myself as a STEM person, and I wanted to be able to keep some of that in those hard science classes that I took. So I also kind of stumbled into public health and ended up getting a BS in public health, BA in medical anthropology and global health. Graduated, my partner at the time was here, my family was here, our friends were here, and I figured I needed a full-time job as an adult. So I ended up getting a job as a research coordinator at Fred Hutch, was working on colorectal cancer studies. And I did that for a couple of years. It was really valuable because I got to engage with patients kind of from their diagnostic appointments through their treatments, often through their final days, talked with them every week, was at their appointments, was at their surgeries. And through that, I got a really good kind of idea about what I would later learn to be social determinants of health. I was seeing all of these different patients from, getting the same treatment at the same centers, living in the same cities, but what brought them to their diagnoses and the treatment they received and the outcomes that they had from it were very different. And so that kind of pushed me to go back to my ideas about public health and what some of the preventative work that people could do to address some of the inequities that I was seeing. So again, I had no experience with education. My family, that was not their background or experience. So I went to the only person I could think of, and I went to the director of the public health department in my hometown. I said, okay, well, if I want to go into health, what do I do? And he said, well, go get a master's of public health at University of North Carolina. So I applied and I got in and I moved across the country. And I spent a couple of years there and it was really great. I learned a lot of really valuable methods and analytic skills, but I was the only Native student in the School of Public Health. And it was really isolating because the questions that were being asked were not questions that I thought were particularly relevant for my family or my community. When I took population health classes, we were never included. I had professors saying, oh, you're too small of a population and you don't matter. And I disagreed. So it was a beneficial experience, but it wasn't quite what I was looking for. So graduated from that, decided to stay in North Carolina for a while. I had a good support system there and I went back to cancer research. I started working with HIV positive patients who had viral malignancies. And North Carolina has one of the largest Native populations east of the Mississippi. So a lot of my patients were Native. And the kind of similar to when I was working in Seattle, I would see that when patients were coming in, the questions that their clinicians were asking them were not the questions that patients were necessarily asking their clinicians, and the treatment that they got was not necessarily. So I decided that if I was interested in asking those questions and I needed to be in a position where I could do that. So I applied for a PhD program at UNC. And I had been through my master's, I had started kind of hanging out in the anthropology department. There weren't any Native faculty there, but there were some faculty who were at least working in areas of Native health. So I applied to the one place I was familiar with, and I got in and ended up doing my PhD there. It was a good move for me in that UNC has an active Native graduate student group and a really amazing American Indian Center. And so through those spaces, I was able to connect with Native communities in the area. There were 2 elders from Okinichi Band of the Saponi and Koheri tribe who brought me in and said, well, if you're going to be over here on the other side of the country, like you may as well be with community. And so I spent 6 years kind of going to classes, doing kind of the standard academic route, and then in the evenings, going to culture classes and weekends doing powwows and gatherings and ceremony. And so that was really great. When I started my PhD program, what I was interested in, similar to Will, was the way in which historical trauma and experiences of systemic adversity impact health outcomes for Native people kind of across time, across generations. So I'm a human biologist. That's what my PhD is in, within biological anthropology. And so I was working in the lab looking at how we might be able to document impacts of historical trauma physiologically. So I was interested in if you have intergenerational exposures to systemic adversity, what does that look like in our bodies? I was looking at compounded allostatic load and outcomes like heart disease. And so a couple years into my PhD, 3 or 4 years, I was giving a talk to a community group in Durham. It was mostly Native and African-American women. And I was talking about kind of the physiological impacts of historical trauma. And then one of my elders and mentors came up to me afterwards and she said, that's really great, but we are tired of talking about historical trauma. We know that it impacts us. We know that it has these outcomes, but that's not all that we are. And she said kind of the other side to historical trauma that's always evoked is resilience. And she said, I'm tired of being resilient, tired of talking about historical trauma, tired of being. So what else is there? What other narratives are there for Native health? How can we move beyond this? And so that was really valuable for me because she kind of startled me out of these ruts that I had been pushed into through the training that I had received and these deficit narratives that I'd been taught that said that Native people have higher rates of every mental and physical health poor outcomes kind of across the board. And she pushed me out of that to say like, well, what else do we have? Because that doesn't define us. And to start thinking about what it was about my family and my friends and my community that had allowed us to survive and thrive through time. So I got married, got pregnant, moved back here to do my dissertation, do my dissertation research. And I was working with some Coast Salish tribes in the region on that. And then COVID hit and collecting biospecimens during COVID was not really feasible. So we ended up having to pivot a little bit. But anyway, so finished my dissertation, was writing it up, was applying to jobs in tribal health. I thought that what I really wanted to do was work for a tribal health department to do research that was driven by tribal questions and was funded internally so that we weren't having to balance a lot of the power dynamics that Will talked about. And I realized really quickly that that job didn't exist. So I was trying to figure out a way to like self-fund myself within tribal health departments and figure out how to kind of create this position. And while I was doing that, a friend of mine from UNC, another member of the Native graduate student group, called me and said, hey, Joseph Gahn at Harvard, who's one of the leading Indigenous health researchers and a community psychologist, just posted a postdoctoral position. You should apply for it. It's like, well, I'm not a psychologist. I'm not going into academia, so I don't think that that's a really good fit for me, but sure, why not? So I applied, and I think the next day Joe called me and said, hey, if you'd like this position, it's yours. So packed up my 2-year-old and moved back across the country to Boston, and did a postdoc in Indigenous community psychology at Harvard Medical School. And while I was there, it was amazing. I was given a lot of free rein to focus on strengths-based research. Community-based research is what I do. So I was given a lot of freedom and resources to pursue that, kind of outside of what would have been possible in other spaces, because most of the funding sources for health research are disease focused. So it's really hard to conduct strengths-based work. So I was really fortunate to be in a space that gave me the freedom to do that. So after a year there, I ended up accepting a position with Washington State University and with IREACH, which is the Institute for Research and Education to Advance Community Health. It's an Indigenous community-based research organization. It's been wonderful. We have primarily Native faculty and staff, and we do community and strengths-based research. So I've kind of landed in a space that is a good community. So yeah, my current projects are all community and strengths-based. I work with urban Indigenous communities and tribal nations across the country, but primarily in the Seattle region and up in Alaska. And yeah, I guess when I first moved back to Washington, Will was one of Joe's previous students, and so I was trying to find connections here, and we looked back in emails and figured out that I was the one who emailed you. But yeah, we had a lot of overlap in our research interests, and started talking about ways to collaborate.
Yeah. And then it was really fortuitous that the next year after we got connected, there was the American Psychological Association at its national conference in Seattle. So I think we just chatted about like, well, there's going to be a bunch of cool Native psychologists and other scholars here in town. Maybe we could do some interesting project. And since we just met, we thought these ideas kept building. We got a number of Native psychologists, counseling and clinical psychologists mostly, interested in, well, some were interested in planning to come to APA in Seattle. We ended up organizing kind of as a ended up being a really helpful kind of trial test run of how we work and think together. This project on Indigenous self-determination and mental health. So we ended up pulling together a writing retreat that brought together like a dozen leading scholars in this area up at the Bothell campus over the summer, last summer, and the summer before, last summer. And we had 2 days of getting to really just think and write together to figure out and think through what was really interesting about Indigenous self-determination in a mental health context, what was being done, what hadn't been done, where was there room for clarification. And that was a really fun way to kind of work together, write together, think together. And I guess it went well enough because now Rachel ended up kind of as that project went from writing retreat to now a special issue, hopefully. I won't name any journals because it's not officially yet, but yeah, hopefully it'll be a special issue of a journal. Rachel brought up and initiated a conversation about just some of the things we're thinking about: community-centered work, strengths-based work, the kind of themes of kind of cultural practices, intergenerational relationships. Before long, we were on a Zoom call with the Coast Salish Youth Coalition leadership, so Sandbar and Aaron Licata. Push this button. That's it. Okay. On a Zoom call talking about some of these themes around cultural practices, intergenerational relationships, their importance for community wellness, some of the things the Coast Salish Youth Coalition what they were doing, what kinds of programs they'd organized, and ultimately talked to the leadership there, and they were really interested and ultimately decided to help support and co-develop with a couple of Coast Salish communities and the CSYC, an intergenerational youth and elder health and wellness program that was organized around kind of 6 months of kind of consistent engagement around community cultural practices that both youth and elders were excited and motivated to learn about. Elders felt excited to teach about and share that knowledge with younger generations, and they felt that they could connect around in a meaningful way.
So I'll just back up a little bit. The Coast Salish Youth Coalition is an intertribal nonprofit that was started by a member of the Samish Nation, who has been one of my good friends since we were kids, which made it really convenient. And then I have volunteered with them since 2015 or 2016. They do a lot of youth programming around traditional cultural practices and getting kids out onto the land to engage in particularly environmental restoration and stewardship work. And so I've worked with them in the past, teaching traditional ways of salmon fishing. So it was kind of a clean rollout. They have a lot of summer and spring programming, but they were really interested in finding ways to continue engaging with the communities that they work with around the fall and winter, and also to bring elders kind of into this space along with the youth to have an intergenerational focus. And so after sitting down and talking, we decided that what would make sense is to have an intervention in which we pair up elders and youths to teach and learn a traditional cultural practice that was valued by both of them. So this is really small on this, I apologize, but this is the conceptual framework that we came up with after a lot of conversation. And what we were really interested in was seeing how engaging kind of across generations and with across generations around traditional cultural practices can promote things like positive Indigenous identity, self-esteem, cultural like confidence in your ability to practice culture, and the literature shows that things like that are really impactful in impacting or in reducing risk of things like substance abuse and suicidality, which unfortunately in the communities that tribal communities we're working in are at epidemic levels right now. So we are looking at a couple of different tiers of outcomes, those some cultural efficacy, self-esteem, and intergenerational engagement impacting positive identity and reducing things like substance abuse, suicidality, and ultimately positively impacting well-being for both youth and elders. So that's kind of the program. We're engaged in a long process of tribal consultation. So we're talking with right now 2 different tribal nations to tailor this general idea to their communities. So some of the tailoring that's come out of that, we were originally proposing that this be youth aged 18 to 25. One of the communities said, we have really high rates of college attendance. Our youth aren't on the reservation after 18, so can we do 16 to 25? So that was one of the tailoring. Another one of the communities said, we have a lot of family in other nearby tribes, so instead of having elders and youth within the same tribe, could we do kind of across some of the tribal nations, but within families? So those are some examples of some of the feedback that we've gotten from the communities that we're talking to. So the idea is we're finalizing this program for each of those communities, go through tribal council review within each of those tribes before it's implemented, and the hope is that we'll be able to start next fall.
We're really excited about. And maybe we transition to some questions, because the first question for you, and so we were going to give a little background, talk about the project, and then ask each other some questions. It was just, Rachel, what are you most excited about related to this work?
Yeah, so I mentioned earlier that it's really can be really challenging to fund strengths-based research. And so this project was a bit of a kind of a balancing act between being responsive to what the communities that we were engaging with were interested in doing, what we believed as scholars was could be documented within the literature and the evidence base, and also being able to find funding for a program so that we could do things like give elders youth honoraria for, you know, each of the sessions that they participate in, and pay for people's travel and pay for food for gatherings and things like that. And so we had to do a little bit of balancing between including things like substance use and suicidality, as well as the strengths-based measures. But I think one of the other things that I'm proud of and that is important within this work is the recognition, even within strengths-based work, that there are still challenges that we're facing. So I think there can be a tendency within strengths-based narratives to say, like, everything is sunny, you know, cultural engagement is going to fix everything. And that's not accurate. You know, we have cultural engagement, it's still existing within systems of structural subjugation, it's still existing, you know, within a lot of reservations. There's a lot of poverty, there's not a lot of access to educational spaces and things like that. And so I think with this project, we've ended up in a place where we're leaning into these positives, desires, strengths-based approaches without neglecting the reality of the sort of systems that we live in, which can be really challenging to do. So, yeah. Go ahead.
Most excited about, so I mentioned that when Rachel and I met, I hadn't had a chance to do strengths-based research in practice. I had thought a lot about it, started to read a lot about it, and so I was really excited about the chance to give it a shot and see what it was like, see what was really rewarding about it, see what was challenging about it, because I had spent so much time thinking about power and concerns around representation, and I hadn't spent a lot of time, you know, exploring, you know, the desires and health goals and wellness goals of specific people, any specific people or peoples, native peoples. So what am I most excited about? One, Rachel and I had spent quite a bit of time talking about the model and some of the different kind of strengths-based measures and things that, particularly the elements, the kind of active ingredients of the intervention around intergenerational relationships and connections to across generations and to culture and to place and to land and waterways. And so far in all of our community consultations, there's been a really lot of enthusiasm. And so that was kind of immediately what I was excited about, that the particular tribes that we're partnering with also appear so far to be really interested and invested and supportive of this kind of thing. I'm also really excited about the partnership with the Coast Salish Youth Coalition. Different community partners at different times, particularly like in where I come from in community mental health, there's often kind of under-resourced and overworked community partners that really have a hard time engaging for long periods of time in research that's highly collaborative and might have other kinds of barriers to participation. But the Coast Salish Youth Coalition leadership, Sam and Aaron, have been amazing partners, and feel really fortunate to have this team that we've got put together.
Sorry, I have a list of questions here. We combine those first two a little bit, but okay, so are the metrics for research like this similar or different to what you would consider standard academic metrics of success or achievement?
Yeah, so I've got a two-part answer. One is I feel really fortunate to have landed in the School of Interdisciplinary Arts and Sciences at Bothell. One of the big motivations was I didn't feel creative or smart enough to know how to embrace like a career of federal funding with work in Native communities without letting that federal funding co-opt a lot of my effort and make the projects undermine some of the goals, because I saw that happening a lot. And so I went to the School of IS at Bothell because federal funding wasn't a requirement of promotion and tenure. And so I was really excited about being in Native community and being driven by the kind of agendas that emerged from there and responding, and without the federal government being an intermediary or, you know, a power player in that relationship. And so and also in that school, we've got everything from artists to health researchers to economists, and you get to really just make your own case, establish your own criteria for success and promotion and defend it. And so in many ways, this work does meet those standards and would be supported both in conversation and in practice, like they would promote you based on it. In my career, in my profession, not so much. In clinical psychology, I'd have a hard time finding other clinical psychologists who I think most would be interested and excited, but then they wouldn't know what to do with it. And so there's real, like, we've had to incorporate things like reasons for life and flip side of kind of suicidality. So there's a number of measures that we've incorporated, both because communities have some concerns and make sense of it in that way, but also because those are things that you need to include in order to get with funding from a federal health organization. And so, yeah, I would say in general, in my profession, it's a challenge to do this kind of work. And I feel very fortunate to have a home base here that does encourage it, but yeah, definitely doesn't meet the same metrics. It takes more time. It's a little bit different. There's a lot more explaining you need to do to translate for how this relates to what other clinical psychologists and other mental health professionals are doing. What about you?
Yeah, so I'm in a different type of position than Will is, in a soft money research-based position. So we have to bring in our funding for our positions as well as the research projects that we do. So it's always a little bit of a hustle. And I think that within the Indigenous Health Institute that I'm a part of, there's the expectation that everyone is doing community-based work, but the way in which you do that, the degree to which your research questions and your methods and your kind of dissemination are truly driven by community differs. And I think despite the fact that there's a push in the surface level desire to be doing these things, the reality is that doing work in this way doesn't adhere to academic or federal funding systems and timeframes. And so like for this project, it will have been over a year of community engagement that we've been doing before we're able to start collecting any data, and that doesn't, nobody wants to pay for that, right? Nobody wants to pay for us to go up to these tribal communities, frequently with food and to sit for a day and talk with people, which is what we really need to do in order to do work like this in the right way. And so when I do my annual reviews, I mark, I keep track of every community meeting I go to. I'm on a couple of local native boards, and I keep track of all of my board meetings, and I keep track of the ceremony and the powwow and cultural events that I go to, because those are all important for me to be able to be part of community and to be able to engage and participate in the ways that I need to be able to do, to feel like I'm in right relation. But none of that will end up being considered in like my promotion and tenure. So it ends up being what I think is called a minority tax. So we do these things because that's what has to be done to do the work in the right way, but it doesn't end up being compensated or considered within like standard research or academic metrics.
Yeah, even funding sources that have been interested in kind of seed funds to build community relationships have often signaled that they want you to have like predetermined what a lot of the outcomes and a lot of the elements and what a lot of the process is. So that's really preliminary consultations that they find funding for. Another question for you, Rachel. Then a long route from human biologist to focusing on mental health and wellness. So I'm curious if you have any insights or lessons about perseverance or finding the kinds of training and mentorship you want to be able to do the kinds of things you do.
Yeah, I just kind of stumbled into things. So there wasn't a lot of forethought. Partly that's my personality, and I think partly that's coming from a family that had experience in higher education. I didn't have a native professor or mentor until my postdoc. So I had some really amazing professors who were open to letting me do my own thing and like letting me spend time in community and kind of working that into my research. But I always felt a little bit adrift. So I think my recommendation for students in similar positions would be to, if you can't find mentorship that aligns with kind of who you are and what you want to do, then find mentorship that will support you to be that person. Yeah.
I realize we've only got 10 minutes left,
Okay.
so I want to make sure we save time and tempted to offer one more question, but maybe we see if there are any questions have been put into the chat. And then if not, then you can pick one.
I have a question for you.
Okay.
Question. You want me to, did you have a question for?
Go, you can ask that one, yeah.
Okay, what is the right way? Really long time. Louder. Okay, what does traditional healing look like to you? What is the right way from your university perspective? It is an authentic. Okay, but, I'm gonna just read this before I read it. Maybe you could address the first part and I will come back to the second part.
So I'll just say something if you want to weigh in, but traditional healing, what does it look like? Depends on the tradition. Different ideas of healing practices and what constitutes healing. It just depends. Yeah, I don't have like a clear answer because there shouldn't be. It just really depends on the context and the tradition and the practices involved. And there is an interesting kind of healing wellness where the line, I mean, there aren't clear cut lines. I don't know, did you want to throw anything in response?
I was just having this conversation yesterday with a group of students, and then this weekend at a Native Health Summit. Because there was a recent Medicaid expansion in 4 states to cover traditional American Indian Alaska Native traditional health practices through Medicaid, and there's a push within Washington State to expand here as well. And so particularly at the Tribal Health Summit that I was just at, there's a lot of conversation about what constitutes traditional medicine. Is it, you know, the foods that you eat, the practices you do, or is it based in spirituality? At what point in time was something, you know, a traditional practice? How does that work in the world in which we all live in today, which we're all modern people? So yeah, I would just kind of add that to Will's point, that it depends on the community, it depends on where you're at, it depends on who you are, your traditions, what you're trying to achieve. And there's not one right answer.
The person was asking about sort of the way that plants and the land have been, also in addition to what you answered, have been subjugated, and like how that knowledge has been tokenized by universities, and sort of how you're thinking about what kind of the right relationship of the university in relationship to knowledge practices, I think, in a way. Yeah, that's my best sorting out of it. And how to preserve the sort of the autonomy and sacredness of plant medicine and traditional knowledge.
So I think the answer for that relates to community-based work in general. So, and for this partnership specifically, it is an equal partnership with the Salish Youth Coalition. They would have been here, but they're presenting somewhere else today. And it's also in collaboration with the tribes. So the tribes that we're working with, we have the project be approved by tribal council. We'll also have data use agreements with the communities. So any knowledge that is gifted from within their community belongs to their community. So we're kind of helping them or facilitating this project that was co-developed. So that doesn't belong to us. Nothing that comes out of it belongs to us. So if those tribal nations are interested in that knowledge being shared outside of their community, that's a decision that they make, not us. I guess the simple answer is the findings from this work don't belong to the university. They belong to the community.
Is there anybody from the room? There's another question. go ahead and ask the second question from online. They're wondering if you would share information about any publications. They thank you for your presentation and wondering if you would share any publications that you've authored around work with community members.
Well, publications related to this, there haven't been, and part of the kind of investment in community consultation and why it's at odds with academic standards of achievement is that spend a lot of time in conversation and dialogue around what to do, how to do it, and what looks and what that should look like. So related to this project, there aren't any publications that are currently available to the public. Still gotta put those data use agreements into place and get tribal council approval. Previous stuff, I don't know if there's anything I really particularly want to highlight other than I'm happy to email like a CV or a list. Specifically, and one that I mentioned, I guess I'll just real quickly say there's one called Incorporating Culture into, I'm not going to remember the titles off the top of my head, but there's one about incorporating culture, that focus group analysis that I mentioned, a couple of different historical trauma papers on community perspectives from two medicine men was one that I wrote, and one about ended up talking about that difference between kind of a social analysis of history and colonialism and its impact on life today versus a psychological one, in terms of what's called psychological mindedness, this propensity and ability to explain the world in terms of psychological processes. So that paper is called like Psychological Mindedness, something, something, American Indian Historical Trauma. But probably that's just a, email, or I'm happy to share whatever the author's interested in.
You have an article on global mental health too, right?
Yes, there's also an article, but I didn't mention that project. I had a clinical ethnography of a behavioral health clinic that really wanted to reimagine behavioral health services for an urban Native community. And that one was very community centered. It was not strengths based, or it was about community interest and concerns and desires about to reimagine behavioral health with ideas of culture and community in mind. I think of a way to wrap it up really quickly that there was one about, there's a publication about rethinking the concept of culture and global mental health and how it might, it's not always safe stream, and that actually institutional and structural context shape a lot of what we can and can't do, even if we can imagine ways of doing it differently. One of the things I'm most excited about this collaboration is that I'm no longer in a clinic context, and there's lots of constraints around bureaucracy, about funding and about reimbursement and about the structure of clinical practice that we don't have to deal with because we're in kind of a like community programming mode as opposed to a clinic that provides services to service users. That's a really constraining environment to think creatively and differently about health.
Any last questions from in the room?
I don't have a question, but I just want to say thank you both so much. This was just so lovely to hear about your histories, your backgrounds, where you came from, and what your journeys are from where you first started to now. It really, like, I was so captivated, and 1 hour flew by so fast. I think this could have been like a couple of hours, if not like all day, because I feel like there's so much that probably we could have unpacked. But I want to say thank you, so much gratitude to both of you for taking the time to share your experiences and your journey. I'm really, really like drawn to the work they all do.
You didn't get a chance to ask your question.
Okay, yeah. We'll just say the last slide, because I need slides, I'm gonna use them all. The last slide has contact information. And a pretty picture of a rock. So if you have follow-up questions or you want to get in touch about anything, feel free to reach out.
And you have more love from the chat.
I'll also say Rachel has some amazing publications that she'd like to not to add, throw in there at the end, particularly around survivance and the health literature. So yeah, lots of stuff. Reach out if you're interested in reading some of those.
If you want to send your CVs with publications, we can send them out to participants.
The easiest way, I'm gonna say, is just Google Scholar.
It's Scholar, you heard it.
Yeah. Thanks, everyone. Thank you.
Thank you so much.